And now it's my pleasure to introduce our last speaker, Dr. Sheraz Yaqub. Dr. Sheraz is a senior consultant in hepatobiliary surgery at Oslo University and a full professor of surgery at the University of Oslo. He is a head of hepatobiliary research group and is a principal investigator on several international multi-center clinical study in this field. He has specialized focus on surgical research in cholangiocarcinoma and is leading the transplant studies in Norway for intrahepatic and perihilar cholangiocarcinoma. So today he will be telling us about pushing the limits and expanding possibility of surgery for cholangiocarcinoma. Dr. Jakob.
Good morning. Thank you for the kind introduction, and thank you for the foundation for inviting me here. I came all the way from Norway just to meet you guys, and I really enjoyed breakfast today as well, sitting with the patients, caregivers, and having a chat. It's all about you guys, and I really, really appreciate being here and look forward to the rest of the meeting. And as concluded, we are here for the patients. We wake up every day, go to surgery, and it's for the patients, all of this. So thank you. Thank you. I'm really, really proud to be here among you. Okay, so my talk is on how to push the limits. Now you heard about what's in the toolbox, so how to use the tools and find the right patients. I have nothing to disclose. So as you heard, surgery is still the only potential curative treatment for carcinomas. And as Tim pointed out, still there are several patients getting recurrence, and we have to do better than this. So it can be pushed the limits of resection to achieve negative margins, as we heard, and improve outcomes. So I'm going to present some cases here today. And for the patients and caregivers, please do not do this at home. And contact your surgeon and discuss with them. I'm going to show you portal vein reconstruction, anti-cytosine resection, ex vivo resection, and some slides on liver transplantation. You've heard about those already. And the new concept of SURE-LT, a superior right abdominal excentuation, followed by liver transplantation, which we just published. To start off with, as everyone has said several times, biology is the king, and we can use surgical tools, but they can't solve all the problems. So if you have favorable biology, we can do the resection, and aggressive tumor biology, we have to avoid resection and futile surgery, as we heard from the previous talker. So let's jump over to portal vein reconstruction. This is a slide of a 50 years old man who presented with an 11 centimeter large intrahepatic cholangiocarcinoma. As you see in the color in green on the CT scan and the scan turning around, there's huge tumor affecting the right and some of the left liver, and both right and left portal vein were thrombosed. He had the drainage of the bile duct, and we did then surgery after neoadjuvant therapy, and we did extended right hemihepatectomy, the resection of the portal vein, and as you can see on the drawing on the top here, we made a shunt from the portal vein to the left portal vein and removed the whole tumor with the affected portal vein as well. And 10 years out, is still no evidence of disease. So let's take over to the next way to operate these patients with anti-cytosine and ex vivo resections. The anti-cytosine resections are for tumors which are in the hepatic vein area. On the top here, against the vena cava. So, to be able to reach these tumors, you have to lift up the liver. So you have to resect the cava and lift the liver. As shown on this image here, you see the liver is lifted up, the cava is open to remove the tumor here as well. I will show some more slides later. Moving on to ex vivo resection and autotransplantation, you actually take the liver out, and then you do the resection on back table. Here you can see The liver veins are resected, liver resected, reconstructed, and you transport the liver back in again to the patient. So when we are pushing the limits of resection, we have to remember that uh, we, there are and there have been some advancements in surgery, both in transplant, transportation techniques and resection techniques, and especially in anesthesia as well. It makes it possible to do these resections and achieve R0 resections as well. Back here. And we just published our first 35, series 35 patients using these techniques. And as you can see on the survival curve, we have done this for benign conditions as well, which have 100% survival. And for the primary liver tumors, we have pretty good survival. Think of these patients as non-resectable and non-palliative care. So I will show you a case with anti-site resection. This is a 44 years old man who has had incidental finding of a 5 centimeter intrahepatic cholangiocarcinoma, which also have affected the all three liver veins, the hepatic veins. He had a biopsy confirming the diagnosis, and after chemotherapy, uh, we did a resection, anti-site resection, where we mobilized the liver. We we did a resection of the left liver, which was going out. And further on, we did a resection of the suprahepatic vena cava, removed the tumor, and made the new hepatic veins with the saphenous grafts. And he's still out here 17 years without evidence of disease. So over to ex-survival resections, which are the extreme surgery here as well. I will show you a case of 50-year-old male who had previous resection for intrahepatic cholangiocarcinoma with left-sided resection. Unfortunately, had a recurrence affecting the right hepatic vein and its branches. So we took the patients to the OR after seeing that we had disease control with oncological treatment. We put the patient venous bypass. We did a total hepatectomy. Here you see the patient's liver on the back table. We did the IVC resection and ultrasound-guided resection of the tumor, followed by, as you can see, the specimen is out, and the tumor is the white area here within the liver tissue with negative margins. We ended up with having 6 liver branches on the right side. And if they're about more than 5 millimeters, we have to reconstruct them. Now, what should we use here to reconstruct this? We took a part of the vena cava from the patient, and we reconstructed all the orifices here for the 6 branches, and we auto-transported the liver back in again. And here you see the CT scan with all the open liver veins as well. This is another case of a 52-year-old woman with a large intrahepatic cholangiocarcinoma, which was verified by biopsy. And she had GEM-CIS for a period, and we didn't find any mutations or untargetable mutations. And I'm going to show you a movie here, what we did with this patient. So we mobilized the whole liver, as you see here. You see the white tumor on the left side of the liver. We cut the vena cava. The patient is on venous bypass. We take the liver out with the tumor and the cava, and we make a end-to-end portocaval shunt, leading the blood from the intestines into the cava while we're doing the back table surgery. On the back table, we dissect off the tumor, and as you can see, this is the vena cava taking off from the left hepatic veins. Because we have to save we have to have the inflow and outflow. Is the proximal right hepatic vein, which is dissecting into the liver to get it free from the tumor. Because as we just heard from a previous talker, we have to have free margins. Then we dissect the pedicle, cut the bile duct. All this is while the liver is cooled down to 4 degrees on back table. So here we have the future liver, which is tumor-free. And then we did a reconstruction of the vena cava and the right hepatic vein. We sutured graft, we used venous grafts and artificial grafts as well, and sutured them to the right hepatic vein orifice. And then we auto transplant the liver back into the patient. As you see here, the heart is beating on the top there. This is the vena cava on the top of the liver, and this is on the lower part. Is the portal vein anastomosis, and then the artery. And you see a stent in the bile duct, and finally we do the bile duct reconstruction. As a post-op images showing good function. Unfortunately, she had a recurrence 5 years later and is on oncological treatment. There's the post-operative images. So I have to talk a little about liver transplantation as well. And since this is pushing the boundaries and extreme surgeries, what's the most extreme resection? It's taking the whole liver out and replacing it with a fresh new liver. And this was presented, as you heard yesterday, talk as well from the Methodist and the MD Anderson group. They presented 6 patients who were on 6 months of at least 6 months of chemotherapy. They were deemed unresectable, and were transplanted. And the 5-year overall survival was 53%, which is really good. The Italians also did the same thing. They published their first 4 patients. What they did was to have patients with liver confined disease, 13 patients. They treated them with the Y9T, and of those 13 patients, 4 patients were transplanted with really good outcome as well. In Norway, I started the Tesla trial. This was before Elon Musk went into politics. So we did the first 5 cases here. 5 patients were deemed unresectable. And they were, after 1 year of oncological treatment, they were transplanted, and 5 years out, 2 of these patients have recurrence. And one is not on any treatment because the recurrence is too small. The other one is on oncological treatment. And now, the last part of the talk, I'm going to tell about pushing the limits for treating perihallar cholangiocarcinoma. You heard about the Mayo Protocol, but there are some restrictions for doing liver resection, as you heard, for perihallar cholangiocarcinoma. It's hard to stage them correctly. It's hard to get negative margins on these patients. They often have small future liver remnant, leading to morbidity and mortality. Um, and when it comes to transplant, again, it's hard to get the right diagnosis. Is it PC structure or is it the cancer? Um, and you have all these steps you have to do before you can get included, which also have both mortality and morbidity as well. And a few patients that can be included. That's actually for all the transplant protocols. So we thought of an alternative path for liver transplantation for perihallar cases. So we introduced the SURE LT concept, superior right abdominal accentration, where you have unresectable perihallar tumors which are not eligible for the Tesla 2 trial or for the Mayo Protocol. And these tumors can also invade the port vein or the hepatic artery. And they can actually have lymph node metastasis within the hilum and not distant metastasis. And of course, the patient has to be fit to get this treatment. So what we do in these patients is what we suggest to do in this patient. We have done 2 cases. Um, After, first of all, we staged the lymph nodes, and especially the lymph nodes outside of the hepatoduodenal ligament, which is the hollow lymph nodes. And then we mobilized the spleen, and the pancreas, as you see, is lifted up here. and we dissect the splenic artery, which is going to be used as future hepatic artery. We take the specimen out with the part of the stomach, duodenum, or pancreas, spleen, liver, cava, and all lymph nodes as well. And we put in a new liver. And what we also do is we take the islet cells from the donor and infuse them into the donor liver so the patient doesn't get brittle diabetes. We just published this concept this year, and we've done 2 patients on this. Of course, it's really highly selected patients with high morbidity as well and really extended surgery, so you have to have the right patients. To sum up, it's all about the patients. So this is a patient I had, and he sent me this picture. He wanted me to show it to you guys. He's a 45 years old farmer. He had PSC and liver cirrhosis, and had 5 centimeter intrahepatic cholangiocarcinoma in segment 8. And segment 8 was the only segment that was functioning in his liver. So he was deemed unresectable. He had first line of GEM-CIS, but had severe side effects. So then he had Y90, and we transplanted him 21 months out in the diagnosis, and is still disease-free. So to conclude, ex vivo and anti-cytokine resections, they are viable options in highly selected cases with, I have to underscore this, favorable tumor biology, and they have challenging anatomy. So as I said, surgery can do something with anatomy, it can't do anything with the biology. Liver transplantation is a feasible option also for highly selected cases with liver-confined disease. And for the patients here, ask your surgeons whether the specialist center offers these options. And of course, again, they have to look into your biology. So refine the patient selection based on genetic profiling, integrating systemic and local regional therapies may further improve survival outcomes. Thank you for your attention, and I'm happy to take questions with the panel.
Thanks very much, Dr. Yaqub, and really to the entire panel of speakers.